Good afternoon. Welcome to the Preventive Medicine Grand Rounds for April 6th. I'm Bob Kirkaldy from the Division of Scientific Education and Professional Development. The Preventive Medicine Grand Rounds is sponsored by the CDC Preventive Medicine Residency and Fellowship, or PMRF, and the Health Resources and Services Administration Bureau of Health Workforce. CDC's PRMF provides 12 and 24-month full-time longitudinal service learning opportunities for senior public and population health leaders, and physicians, veterinarians, and nurses who have completed the EIS program or equivalent public health experience. We use Zoom for the audio and presentation and the question box to pose questions. Note that you can pose questions via the question box at any point during the lecture, and the speakers will answer questions following their presentations. Note that your name may appear associated with the question that you posed. If you don't want your name to be associated with the question, please check Submit Anonymously when you submit it. We do have two speakers today, so when submitting a question, please note whether it's directed toward the first or the second speaker. Continuing education credits are available for the live course up to 1 month after today's presentation date, and for the recorded version up to 2 years from the date of presentation through the CDC Training and Continuing Education, or TCE, online portal. The course code for this Grand Rounds is all capital letters, CDC PMRF. If you have any questions, please consult the Preventive Medicine Grand Rounds website. Please remember that the views presented by the speaker are theirs alone and do not represent the views of CDC, the Department of Health and Human Services, or the US government. We will take our usual moment of silence for our colleagues, friends, and families who have dedicated their time, energy, and sometimes lives fighting the COVID pandemic. We have two speakers today for today's Grand Rounds. The first speaker will be Dr. Meagan Chuey, and her talk is entitled Doula Reimbursement, Improving Maternal and Infant Outcomes. Following her talk, we'll take several minutes for Meagan to answer questions from the audience that we've received via question box. So we welcome our first speaker, Dr. Chuey.
Excellent. Thank you so much for that warm welcome. And hi, everyone. Thank you so much for joining us today. I'm very excited to be here and be sharing about Michigan's efforts to increase access to doulas with the purpose of improving maternal and infant health outcomes in our state. So a little bit about my background. I'm a certified nurse midwife with a PhD in nursing, and I'm currently a Preventive Medicine Fellow where I am assigned to the Michigan Department of Health and Human Services, or MDHHS. In Michigan, I'm split between the Division of Maternal and Infant Health and the Life Course Epidemiology and Genomics Division. I am from the state of Michigan originally, and I am thrilled to be supporting public health in my home state and where my heart is. So to start us off and to provide what I think is the biggest takeaway of this presentation up front, I want to start by highlighting that doulas, who are trained professionals that provide continuous one-on-one support to pregnant, laboring, and postpartum people, are a cost-effective intervention to improving maternal and infant health outcomes. And increasing access to doulas in high-risk populations can be used as a tool to reducing disparities in these outcomes. The objectives of this presentation are to explain what doulas are and the types of care that they provide, what the benefit of receiving support from a doula is for pregnant people as well as for their infants. I'll talk a little bit about the current context of maternal and infant health in Michigan, including racial and ethnic disparities. And then I'll talk about the doula workforce in Michigan and ways that we are working to increase family access to doulas as an intervention to improve maternal and infant health outcomes broadly, as well as reducing disparities in these outcomes more specifically. So what is a doula? Doulas are trained birth workers who provide non-clinical, emotional, physical, and informational support to pregnant people and their families before, during, and after birth. Doula trainings typically last about a week, and many different organizations offer them, including organizations that have a focus on the care of Black, Brown, and Indigenous pregnant people and their families. There are multiple organizations that certify doulas, one of them being DONA International, DONA standing for Doula Organization of North America. The requirements for becoming certified include completing a doula training course, taking additional classes in childbirth and breastfeeding, completing additional required reading, and providing documentation of birth support provided to families, as well as evaluations of that support from both healthcare providers that have witnessed your work, as well as the families that you have supported. So practically speaking, what does this look like? Well, doulas may act as an advocate for someone who is in labor by helping to communicate a pregnant person's preferences with their healthcare team, or to support a pregnant person's self-advocacy. They provide physical and emotional support and encouragement throughout labor, and they communicate with their clients and clients' families about their progress during labor, to help them understand what it is that they're experiencing. And I want to pause to answer the question why an existing member of a healthcare team, such as a nurse or a midwife or a physician, does not fill this role as someone that provides continuous one-on-one support to someone in labor. So within the context of our modern institutional birth environment, these other providers frequently have responsibility to more than one laboring person at a time. And they may spend a large proportion of their time charting or managing technology. They may be working in an environment that is short-staffed or have competing demands, whereas a doula is uniquely positioned to support a pregnant person one-on-one for the entire course of their labor. Two large national maternity organizations, the American College of Obstetricians and Gynecologists and the American College of Nurse Midwives, both formally recognize doula support during labor as an effective and inexpensive intervention to improve maternal and fetal outcomes. According to a 2017 Cochrane database systematic review, continuous support in labor may improve a number of outcomes for both the pregnant person and their baby, and no adverse outcomes have been identified from receiving this type of support. This type of continuous support from a person who is present solely to provide that support, who is not a member of the pregnant person's own network, who is experienced in providing labor support and has at least a modest amount of training, such as that of a doula, appears beneficial. So what exactly are these benefits? So for pregnant people, the support of a doula in labor has been associated with a decreased use of pain medication during labor, an increased likelihood of having a spontaneous vaginal birth, and a decrease in the risk of a cesarean section, with cesarean section being a major abdominal surgery that has potential risks to both the person delivering the baby as well as the baby. Support by a doula is also associated with the lower risk of having an instrumental vaginal birth, such as a vaginal birth associated by forceps or a vacuum. In 2019, the American College of Obstetricians and Gynecologists reaffirmed its consensus on the safe prevention of the primary cesarean, acknowledging that a rapid increase in cesarean birth rates did not have accompanying decreases in maternal or neonatal morbidity or mortality, raising concerns that cesarean delivery is overused. In this consensus, they discussed the continuous presence of a support person, such as a doula, is one of the most effective tools to improving labor and delivery outcomes. The benefits of a doula for pregnant people also include a shorter length of labor, with people who receive continuous labor support having on average 0.7 hours shorter labor. It may not seem like a lot unless you've been in labor or seen someone in labor, and know that 0.7 hours may still feel like a lifetime. Pregnant people are less likely to report symptoms of postpartum depression, and they're less likely to report negative feelings about their birth. And I want to pause on this one because while it may seem less important than the other benefits, I think it also deserves its own moment. A systematic review examined the factors that were associated with someone's satisfaction with their childbirth experience and found that 4 factors predominate: the amount of support from caregivers, the quality of relationships with caregivers, being involved with decision-making, and having high expectations or having experiences that exceed expectations. I think it's important to highlight that doulas can contribute to all 4 of these factors, and so have the potential to play an integral role in the satisfaction that a pregnant person experiences in their labor and delivery. Additionally, negative feelings about birth can lead to psychological birth trauma, a phenomenon that can affect the birthing person's mental and physical health, their ability to care for or bond with their infant, and can impair their familial and social relationships. And what about the babies? Well, doulas also improve outcomes for infants with a decrease in the likelihood of a low 5-minute APGAR score, the score being a measure of newborn health immediately after birth, and doulas being associated with reductions in preterm birth. For these reasons, the Centers for Medicare and Medicaid Services expert panel on improving maternal and infant health outcomes in Medicaid included providing coverage for continuous doula support during labor among its recommendations. Doula support has been recognized as a cost-effective intervention for state Medicaid programs, due in particular to its association with reductions in preterm and cesarean birth, both of which can be costly to the payer. For instance, a cesarean birth costs approximately twice as much as a vaginal birth. A 2016 study found potential savings associated with doula support when doulas were reimbursed at an average of $986, given the cost savings of these two specific outcomes in preterm birth and cesarean birth. So why does doula care have these effects? Well, there are two theoretical explanations for why having a continuous support during labor has these impacts. The first thought is that the modern birth environment can be stressful, threatening, and disempowering for the pregnant person, and that these feelings may have an adverse effect on the progress of labor and on a pregnant person's feelings around confidence in parenthood. The other theoretical explanation suggests that labor support, including encouraging mobility and the effective use of gravity while in labor, as well as recommending specific positions for a pregnant person's body for specific situations, may enhance the feto-pelvic relationship, or the relationship between the fetus and the pelvis. This could enhance the passage of the fetus through the pelvis and soft tissues and decrease the stress response, reducing the likelihood of a surgical delivery, such as a cesarean section, and increasing a pregnant person's feelings of confidence both in their body and in themselves. Studies have demonstrated that anxiety during labor is associated with high levels of the stress hormone epinephrine, which may result in abnormal fetal heart rate patterns in labor, resulting in an emergency cesarean section, decreased uterine contractility, and low APGAR scores in a newborn. Both of these explanations speak to potential decreases in stress and anxiety in the pregnant person, creating a potential pathway for these positive effects. However, despite these benefits to pregnant people, to babies, and to payers of healthcare costs, only 6% of pregnant people utilize a doula during childbirth. There are a few barriers to utilizing doula support that contribute to this low rate of uptake. Primarily, doulas are infrequently reimbursed through insurance and therefore are less accessible to families who are not able to afford cash payment for services. Bearing in mind that while individual doulas may structure their businesses uniquely, generally, when doulas provide support to a family, they are committing to multiple prenatal visits with the family, to provide care during labor, which can be lengthy, and the commitment that they will be available to support a pregnant person from 36 weeks through 42 weeks of gestation, as birth timing can be unpredictable. Additionally, doulas will generally also provide at least one visit postpartum. This adds up to a very significant amount of time spent with families. So if doulas are to make a living wage, their compensation level may be higher than many families can afford. Challenges to obtaining reimbursement from payers include the fact that many states do not license or register doulas as a provider, which is often mandatory to be reimbursed by a large payer such as Medicaid or a private health insurance company. 5 states are currently actively reimbursing doula services on Medicaid plans. And in 2021, 28 state bills were introduced in 17 states and in Washington, D.C. related to Medicaid coverage for doula care. Some states have bills that do not immediately cover doula care for people who receive Medicaid, but rather established pilot programs in the state or had introduced bills to form a committee or commission to study the outcomes of doula care on maternal health. Additionally, 7 states are currently in the process of implementing Medicaid doula benefits. One of the states that has implemented Medicaid reimbursement of doulas is Oregon. However, utilization of this reimbursement has been extremely low. Between 2016 and 2018, only 121 claims for doula services were submitted to Medicaid, with 92 reimbursed over the 3 years. Doulas in Oregon have reported that low reimbursement rates and barriers with the billing process have deterred widespread utilization. Additional barriers included a lack of funds for doula trainings, challenges accessing state certification requirements, lack of support for doulas by the medical community, and limited doula services in rural areas. being cognizant of challenges that other states have experienced in the pursuit of doula reimbursement may be helpful for other states to avoid or actively mitigate similar issues when considering strengthening the doula workforce in their own state. To contextualize doula access and reimbursement within the state of Michigan and our current maternal and infant health landscape, we know that Michigan's infant mortality rate of 6.3 per 1,000 live births is higher than the national average of 5.6 per 1,000 live births, that there are persistent racial disparities in this outcome, with Black infants being about 2.5 times more likely to die in their first year of life than white infants, and being 1.6 times more likely to be born premature than white infants. We also see racial disparities in maternal mortality and morbidity outcomes. For instance, with maternal mortality rates 4.5 times higher in Black pregnant people than white pregnant people. In terms of primary payers for pregnancy care in Michigan, Medicaid paid for 44.6% of Michigan births in 2020, in line with the overall United States of 43.4% of births involving Medicaid. In 2021, Governor Whitmer of Michigan proposed a $37.5 million initiative dubbed Healthy Moms, Healthy Babies as an investment to enhance health programs for pregnant people, new parents, and their children. This proposal was designed to enhance health programs for pregnant people, new parents, and their children, designed to reduce infant mortality rates and address racial disparities that exist in care provided to pregnant people and their babies. Healthy Moms, Healthy Babies included an update of state policy to fit the needs of pregnant people, including expanding postpartum healthcare coverage for low-income people to a full year after giving birth, having a first postpartum visit within 3 weeks and a comprehensive visit within 12 weeks. This proposal included strengthening partnerships between public health and healthcare providers and universities to work collaboratively to address health disparities. And additionally, access to evidence-based home visiting programs was expanded. Home visiting programs being an evidence-based intervention demonstrated to improve health outcomes of pregnant people, parents, and babies, and improve school readiness and family self-sufficiency. It connects more families with services and addresses social determinants of health like housing, food security, and safety. Our division within Michigan's Health and Human Services, or MDHHS, the Division of Maternal and Infant Health, has been working to establish strong partnerships with doulas and advocates statewide, acknowledging that these partnerships are essential to increasing access to doulas. These efforts have informed the work of the Mother-Infant Health and Equity Improvement Plan in Michigan, and doulas currently sit on multiple maternal and infant health committees and actively participate in Michigan's regional perinatal quality collaboratives. Understanding the importance of doulas in improving maternal and infant health outcomes, and as a next step in improving access, Michigan Medicaid is currently crafting language for doula reimbursement, and they're drafting this after working with maternal and infant health stakeholders in the state and conducting doula roundtables. And we anticipate that this language will be posted for public feedback shortly and anticipate quite a lot of feedback from our community. As part of an extension of Healthy Moms, Healthy Babies, the Division of Maternal and Infant Health proposed a doula training and continuing education plan to improve access to doulas for Michigan families. This proposal included 5 core pieces that I'm going to walk through briefly, as well as how we're going to measure our success or our goals in rolling out this program if funded. The pieces of the proposal included facilitating a training program for new doulas and a registry of certified doulas, establishing a doula advisory council, providing continuing education to establish doulas, and providing for 2 doula specialist positions with Michigan's Department of Health and Human Services to facilitate the success of implementing these efforts. The first piece of the proposal was to establish a doula training program. We were seeking funds to provide training for 300 doulas annually. We would provide scholarships to cover the cost of training, as well as compensate participants for their time to attend the training. Scholarship awardees would be determined by the MDHHS doula specialists using a scoring matrix designed by the Doula Advisory Council. The doula specialists and advisory council would also work to identify and approve doula training programs that are diverse, including programs that are explicitly focused on providing training for doulas who are Black, Brown, and Indigenous, so as to prepare doulas that are culturally, racially, and ethnically congruent with families in Michigan. The goal with this program would be that scholarships would be utilized by 300 doulas annually, and the majority of scholarships provided to Black, Brown, and Indigenous people. We know that Black pregnant people are 4 times as likely to die in childbirth than white pregnant people in the state of Michigan. So this goal was developed with this in mind and recognizing the importance of racial and cultural congruence between people seeking healthcare who are at the highest risk and those on their support team. Doulas who have completed doula training from a state-approved entity would be eligible for certification by the state of Michigan and participation in a state registry of doulas. A doula registry would allow families to easily access information regarding Michigan doulas, including areas served, services, and ability to accept insurance. Increasing ease of access would improve uptake of services. Additionally, the registry would provide a centralized location for managed care organizations to access standardized and collated information for purposes of possible reimbursement and data collection. The registry would be located on the MDHH website and managed by the MDHHS doula specialists. The goals for this registry were that 300 doulas would be added year 1, and that 40% of doulas on the registry would serve families in Southeast Michigan, as this is where 40% of births in the state occur. As part of the Maternal Infant Health and Equity Improvement Plan, Michigan was committed to authentically engaging with maternal and infant health stakeholders. The development of a doula advisory council as part of this proposal would provide an avenue for transparent and streamlined decision-making pertaining to doula training, certification, and data collection. The council would determine the scoring matrix for applications to the MDHHS-funded training program. Establishing formal communication structures would allow the state and partners to quickly identify and respond to emerging issues within the doula workforce. The goals for this advisory council are that they would be established and have their first meeting by month 6 of year 1, and that they would continue to gather and meet at least quarterly. MDHHS would provide annual continuing education opportunities to doulas, with the intention of including a doula track during MDHHS's annual Maternal Infant Health Summit, providing updates on pertinent information regarding prenatal, birth, and postpartum care for families. Continuing education would address crucial topics, including those that are associated with maternal and infant mortality and morbidity, such as severe maternal warning signs, trauma, intimate partner violence, racism and bias, mental health, substance use disorder, and social determinants of health at the root of inequities in Michigan. Additionally, funds would be awarded to stakeholder partners to provide continuing education opportunities within their communities. There are many goals for the continuing education, knowing that it is essential to recruiting and maintaining an informed and effective doula workforce. The goal is to have at least 2 continuing education programs funded by the state annually, and that half of certified doulas would attend at least 1 state-funded continuing education program annually. We would plan to have feedback surveys distributed to participants of these programs, with the goal of at least 80% of attendees reporting being satisfied with the programming, and at least 80% reporting being likely to integrate the education topics into their personal practice. The MDHHS doula specialist positions would work to advance and support doula care in Michigan. The position would support the Doula Advisory Council, develop, maintain, and promote the registry of certified doulas, develop, coordinate, and promote the doula training program, and promote the provision and benefits of doula care in the state with internal and external partners. These positions would fall under the Division of Maternal and Infant Health and would be essential to the success of the rest of the proposal. As with any new initiative, it's important to be mindful of potential reactions and concerns of the local community. For us, that means being cognizant of and responsive to the concerns of existing doulas in Michigan. We know that many doulas in our state desire the ability to obtain reimbursement for services billable by Medicaid. However, there are also concerns of some doulas who may oppose state oversight and disagree with the requirements for certification and supervision to be eligible for reimbursement. In terms of the healthcare provider community, national organizations of physicians, midwives, and nurses have acknowledged the benefits of doula support, as I've previously discussed, and are generally supportive of increased oversight of care providers through formal education, certification, and registration. As for other maternal infant health stakeholders in the state, many have indicated they'd be in favor of statewide partnerships in doula registration and reimbursement as a means to increasing accessibility of doulas for families, improving reimbursement, and maintaining standards for training. In pursuit of birth equity and in response to unacceptable disparities in birth outcomes, many partners in the state, such as community-based organizations, regional perinatal quality collaboratives, and maternal and infant health stakeholders, have begun to build meaningful relationships with local doulas. In addition to advocacy and education initiatives, organizations statewide have identified doula access as a priority and are working towards some form of partnership funding or pilot project with local doulas. So what happened to our proposal to expand Healthy Moms, Healthy Babies for doula services? Well, I am thrilled to share that the governor included this funding in her proposed budget for fiscal year 2023, and I'm hopeful that it will pass the legislature to begin being rolled out late fall. We are eagerly awaiting language from Medicaid regarding the reimbursement of doulas for their services, with the hope that doulas that we are able to train with a funded proposal would then be able to go on to receive reimbursement for supporting families that are covered by Medicaid. Our proposal seeks to address the challenges and barriers that doulas and doula organizations had voiced in other states with introduction of Medicaid reimbursement of doulas. And as we've seen historically that private insurance companies frequently craft language similar to that which Medicaid crafts, there's potential for other large payers to follow suit after Medicaid. And lastly, our team is working to partner with other departments and organizations to ensure that the doula workforce is well equipped to provide support for all pregnant people. So we are working on partnerships to train doulas to support pregnant people who have substance use disorders, as well as working on providing training on supporting pregnant people who have a history of childhood trauma, as these situations may require increased knowledge and sensitivity. And with that, I will close, and I am more than happy to answer any questions during our Q&A section. Thank you all so much for your time.
Thank you so much, Megan. That was fantastic. So we do have a few questions that have come in. The first question is about the scholarship for doula trainings. Can you talk a little bit about who are the interested parties and the decision makers who developed the scholarship for doula trainings? And also a follow-on question is about the funding of it. Is it a line item in the state budget, or is it funded through CMS or the health department in Michigan?
Yeah, thank you. So the proposal that we wrote, Michigan has a structure in place where the governor has discretionary funds. And so divisions within the state can write proposals for use of those discretionary funds. And then the governor can choose with those discretionary funds what can be funded. And so the training piece that I walked through, those kind of 5 pieces of the proposal, fell under a proposal sent to the governor that she can decide how to use with her funds. And so that's what she has put in to the proposed budget for fiscal year 23, coming out of, I believe, general funds. The Medicaid reimbursement, Michigan Medicaid is handling that. That would be reimbursed through state Medicaid.
Okay, thank you. And you have a lot of questions rolling in, so thank you very much. Keep the questions coming. So the next question is, will the doula certification potentially be a dual certification that includes midwifery?
No, separate. The state of Michigan does license midwives, but that was, they have their own licensure regulation process. They would be 2 separate things.
Thank you.
Midwives being clinical providers. Oh, sorry. Midwives being clinical providers and doulas being emotional support in birth.
Thank you. What are examples of the state-approved entities for doula certification? And what is the proposed doula reimbursement rate in Michigan? And I wanted to follow on that from a question that I had as well. you did mention that there was concern in states that had that were currently doing reimbursement, that reimbursement rates were low. So if you could talk a little bit about that, what low means in that case. But not to throw too many questions at you. The first one was, what are examples of the state-approved entities for doula certification, and what's the proposed reimbursement rate in Michigan?
Yeah, so in thinking through the proposal, we did not have a list of trainings that would be approved for registration or that we would fund with the scholarship. The idea is that a doula council would be the ones to make that decision. They would take into consideration feedback from the doula community, being cognizant of the diversity of the state of Michigan, and really wanting trainings that speak to the breadth of diversity in the state. And then that would be a decision that the doula council would come to a conclusion on. So the proposal did not specify a list of trainings. In terms of reimbursement rate, the first state I mentioned, Oregon, having low rates of engagement that have been reported with reimbursement of doulas. So the reimbursement that they had in Oregon, and this was what was published in 2019, was the latest that I found, covered 2 prenatal and 2 postpartum visits at $50 each, and interpartum care at $150 for a total of $350 for total reimbursement. Minnesota had an initial in 2014 reimbursement of $411 that was raised to $770 in 2019. And they have seen a higher engagement with Medicaid in submitting more claims for reimbursement. So that higher, the 770 has certainly been higher. I'm not aware of the language that Medicaid is writing currently. I know that they have met and have conducted doula roundtables to gather feedback from the community. So we are awaiting the language that they have in their proposal that will be out for public feedback after that is shared.
Thank you. Okay, the next comment and question, or thank you for walking us through this fascinating program. I'm curious if there's any risks, and I'm also going to add downsides, to expanding access to doulas, and how can those be mitigated?
Oh, interesting. I can say that the Cochrane review, when they were talking about the benefits of doulas, explicitly said that they did not see any risks associated with support provided by a doula. So I can point to that. Nothing is coming to the top of my head right now as I'm thinking about it. Yes, there have been benefits.
Thank you. The next comment actually applauds you for using gender neutral language when referring to pregnant people. So wonderful presentation. Thank you so much. And the next question is, can you describe more about your last point about specialized training for doulas to support pregnant people with substance use disorders, and who are the envisioned partners for that?
That's an excellent question. I know that our division is working with internal partners to craft training for doulas to provide specialized care. I'll be honest, I don't know exactly what that training looks like. It's currently under development. But if you reach out to me by email, I am more than happy to provide more information or answer that question further and connect you with anyone or someone that can answer that question if I'm not able to.
Thank you. Okay, we're doing okay on time. So the next question starts off with excellent presentation. Delaware is actively working on doula reimbursement. Or I guess the question, is Delaware actively working on doula reimbursement, whether you know of? And can you talk about the details of credentialing, the regulations, I believe, regs, and also the doula registry? Is the registry maintained by the division licensing boards? or by public health?
All right, I'll take that one step at a time. Is Doula working towards this? I don't know right off the top of my head. There is a national law organization that is actually doing a lot of work around Medicaid reimbursement of doulas. Again, if you shoot me an email, I'm happy to provide you with that link. And they walk state by state who has past bills, active bills, and where each state is. They've got a brilliant spreadsheet that they seem to update very regularly. And so if you are not able to find that on Google, I'm more than happy to send you a link for it. Just reach out to me. Details of credentialing and registry. So the registry would be totally optional if doulas are interested in having their information collated, so to have easier access, or as a point of easier access for both clients and payers, that would be maintained by the doula specialists that are situated in the Division of Maternal and Infant Health, is the current idea. Just a basic spreadsheet, but as a point of reference for people that would find that information helpful.
And that is a state, part of the state
Yes.
health department?
Yes. Yeah.
Okay, thank you. Do you know of any interest from private insurers about interest in reimbursement?
No, but we have seen historically in the past that once Medicaid crafts language on something, private insurers may then model language that they have for reimbursement on what Medicaid has written. And so it's not outside the realm of reason that might be the case here, but I don't know of any private insurers that are currently crafting language.
One question too is, does reimbursement, does it depend on where the care is rendered? So if it's like in a clinical setting or a hospital setting or versus home birth, do you know if there's differences in terms of whether reimbursement is allowed?
So we'll have to eagerly await Medicaid's language for the reimbursement plan. In the reading that I have done in past states, I have not seen that specified in what I have seen. And in knowing that states that cover such as prenatal and postpartum visits, those are generally in people's homes. I have not seen language that explicitly kind of makes a difference between interpartum support that is done at home versus inpatient. But yeah, we would have to wait to see Medicaid language for that.
Okay, excellent. What do you envision are the biggest facilitators and barriers to implementation of this program?
I think that the biggest facilitator, hands down, is feedback from our community, both the community of doulas as well as communities of pregnant people in the state of Michigan, making sure that there are seats at the table for the people that will both be providing the care and benefiting the most from the care. In terms of barriers, I think it has been pointed to quite clearly that low reimbursement has been a very significant barrier to doulas being willing to go through the bureaucracy of seeking reimbursement from Medicaid. And we've seen that in very low numbers of reimbursement in Oregon, where they were only reimbursing $350 for full care. From what we have heard from doula communities, lack of continuing education, lack of support is also a significant barrier, which is the idea of the proposal to really provide wraparound services to fill in gaps and heed some of those barriers before they happen, and ideally prevent some of them from happening in support of the workforce.
Thank you. This is sort of a multi-part question, is about the Doula Council. How will the Doula Council be engaged and supported? Is it voluntary? And the person who's writing in mentioned that there's been challenges at times with doula engagement if it's sort of an additional unfunded expectation on their time. I'm wondering if you could speak to that or what thoughts you have.
Yeah, that's an excellent question. And I would certainly hate to add burden or increased ask or needs of the state on doulas. We generally do pay people for their time, for their effort, for attending meetings. I, to be honest, am not certain how, like, I can't speak to an amount that is written into a proposal, but we do we prioritize the engagement of the community highly and seek to reduce any burden on their time or energy on meeting.
Okay, thank you. So there's a few, I'm just going to sort of summarize of a few more comments from other locations who have chimed in. So one person chimed in about Delaware and said, as the CMO of Delaware Medicaid, I can say, yes, we are working on this. And we are in the doula stakeholder engagement phase, working with our Division of Public Health, community doulas, and other stakeholders. Someone else chimed in and said, great presentation, and mentioned that New York City is working to expand doula access, and that may be an area where Michigan potentially could learn from, perhaps learn from each other. And someone else mentioned that Rhode Island is offering a benefit for both public and private insurers. So thank you all for those comments, that information. Let's see, we'll have time for maybe one or two more questions. And I will say, if you have continued questions about this, feel free to put them in. We'll see what we can get to, but please note, please try to make it clear to which speaker the question should be addressed to if we have time at the end to double back. With support to being one of the challenges, is there support for doulas as part of a medical team in institutional spaces like hospitals?
Yeah, that is an excellent question, and I think is highly dependent on the hospital. I know that there are hospitals in the state of Michigan that offer free doula services on like a volunteer doula basis. We have hospitals that are trying to get doula programs up and running. In thinking through opportunities for continuing education of doulas, that is certainly a point of opportunity, as well as opportunity for reaching out to hospitals to help facilitate some of those conversations. But I think it's very hospital dependent.
Okay, thank you. Let's see, a comment that chimed in, Oregon doula here. Actually, my New York accent almost just came out. The state is reimbursing $350. This is for members that have private insurance and an Oregon health plan is secondary, or for members that are undocumented. But if the client is on a managed plan, we have an opportunity to negotiate rates that go from $500 to $1,200 plus. And then Oregon Doula Association is working with Oregon Health Authority to raise the $350 rate. Okay, so I think we have time probably for one more question. Are there national specializations to be aware of, to be covered for future reimbursement, or will this come with the unveiling of Medicaid's language?
Can you say that?
I'm not sure if I understand the question. Yeah, I'm not sure if I understand the question. Are there national specializations to be aware of to be covered for future reimbursement? Perhaps we could, if we're not sure, maybe we can seek more information from the questioner if you're not sure.
Yeah, and I can say broadly that we don't know anything about what Medicaid is suggesting until we see their kind of reimbursement language that they're using. So yeah, I'm not clear exactly what you're asking. Feel free to reach out to me if you want to chat more about it or have kind of a specific ask. But I think a lot is waiting until we see the exact Medicaid language.
Okay, excellent. Well, thank you so much, Dr. Chuey.
Thank you all.
Excellent presentation. I certainly learned a lot. So we are now turning to our second excellent speaker today. Our second speaker is Makeda Vanderpuije, and her talk is entitled Evaluating Multi-Sector Public Health Work, Challenges and Solutions. Please join me in welcoming our next presenter.
Hello and good afternoon, everyone. Really is my pleasure to be here speaking with you all. My name is Makeda Vanderpuije. I'm a public health analyst at DC Health. That's the District of Columbia Department of Health, Office of Health Equity. And I'm also a 2021 CDC population health training in place program learner. And I'm going to be talking with you all about my experience evaluating a multi-sector public health effort and some of the challenges that I've come across, as well as potential solutions. I wanted to just note that there are no relevant financial or non-financial relationships to disclose, but I did want to acknowledge that the DC Calling All Sectors initiative, which I'll reference many times in this presentation, is supported by a grant from the Health Impact Project, a collaboration of the Robert Wood Johnson Foundation and the Pew Charitable Trust. And so today I'll be talking really mainly about evaluation of this multi-sector collaborative effort called DC Calling All Sectors. I'll start by describing a bit about our initiative. I'll talk about the value of evaluation, do an overview of CDC's framework for public health evaluation, and then I'll go into how the framework was really put into practice in our project and how this iterative model can be used to plan and the changes that we were able to make to actually put that into practice. I'll then share some insights and look forward to answering any questions that come up. So DC Calling All Sectors Initiative, or DC CASI as we call it affectionately here, was really initiated in 2019 via funding from the Health Impact Project. And so there were 10 states, including the District of Columbia, that were convened via Calling All Sectors. State agencies joined together for health. The goal was to apply a health and all policies model to addressing population health issues. And all of the states were working on the issue of maternal and infant health, though there was latitude in determining a sector of focus outside of health that would be leveraged to make an impact on health outcomes. And so other states did education, or they may be looking to explore their substance use disorder treatment systems. And in the District of Columbia, we focused on the intersection of health and housing. So why housing? We know that though homelessness has been trending down in the District of Columbia in recent years, housing affordability is still a very big issue. In 2019, there were 815 homeless families, including a total of 2,646 family members, and children made up 60% of those individuals who were experiencing homelessness. The scale of homelessness in DC dwarfs that of similar jurisdictions like Baltimore, where 0.3 of the population experiences homelessness compared to 0.9% of district residents. The root causes of homelessness are really varied, and the impacts, especially to infants and young children, are similarly complex. But we do know that social and structural determinants of health play a role in contributing to levels of homelessness, and especially in the racial disparities that we see in our homeless population. So there are 86% of the DC residents that are experiencing homelessness are Black, while only 46% of our residents overall are Black. And so there is certainly a disproportionate proportion of individuals who are experiencing homelessness compared to the makeup of our population. And we also know research shows that the experience of homelessness and housing insecurity can contribute to a birthing individual experiencing poor health outcomes or their infant experiencing poor birth outcomes. And these outcomes really span throughout the life cycle, impacting from infancy all the way into adulthood and throughout life. So that's why the District of Columbia chose to look at housing and housing insecurity as our areas of focus for this project. I will note that, and we'll talk about this, I'll talk about this a bit later, our focus really has come to be more narrowly defined on individuals experiencing homelessness as well as pregnancy as time has gone on. So the Calling All Sectors Initiative, DC CASI, is a collaborative interdisciplinary effort working to better understand the impact of housing insecurity and homelessness as a contributing factor in perinatal and infant health outcomes in the District of Columbia, and to better coordinate the systems that work with pregnant and parenting individuals who are seeking housing support services in the district. That's DC Health, Office of Health Equity, serves as the backbone organization for this initiative. And we are so honored and lucky to have many great partners on the table. As you'll see with many of the other states who are engaged in the Calling All Sectors initiative across the nation, it really starts with a core of district, or I should say, government officials and agencies. And so when we started, we had a number of collaboration sort of partners ready to go to engage with us on this issue, because we recognize that though we hadn't previously worked together in the areas of addressing pregnancy and those experiencing homelessness, this was a really important and critical issue that we wanted to be able to more effectively address. So our Interagency Council on Homelessness is in our Executive Office of the Mayor here in the district, and they were one of our very early partners. We also partner with the DC Department of Human Services, with the DC Housing Authority, Thrive by 5, which is an office focused on early childhood health in the district, as well as the Department of the Office of Housing and Community Development. And we've since really broadened our scope and have worked with other partners like the Department of Healthcare Finance as needed, as we really think about how we are going to have a lasting impact in this work. That really began in 2019. So we have also a very valuable community-based organizational partner who has been a very valuable asset to this team, and that's Community of Hope. They are an organization that serves as a federally qualified health center and also a birthing center. And they also happen to be one of the district's providers of housing services, providing shelter and housing support counseling to families. So they are very uniquely positioned at the intersection of health and housing and pregnancy, and have lent a great deal of perspective and assistance in supporting relationships with community members and other healthcare and housing providers. So as I mentioned, our aim is really to improve perinatal outcomes and advance equity in the district through this initiative. And we really focused on examining and addressing pathways and barriers to health improvement for residents at the intersection of homelessness and housing insecurity. We are looking to do that through engaging providers and engaging residents so that we can better equip ourselves with an understanding of the system and its impact on residents, so that we can inform policy and practice, improve housing security, and improve birth outcomes. So now I'm going to talk a bit about our evaluation and why it's so important to evaluate efforts that are collaborative. This is certainly not a research study that is occurring in a lab. It's very much an applied practice that's continually changing and adapting and iterative as new policies emerge, as life and world events such as the coronavirus pandemic emerge. These all create changes that have impacted the way that we've been able to implement our program. But even so, it has been really critical to keep in mind to evaluation. So our evaluation plan is really a written document that describes how a project will be monitored and evaluated. An evaluation plan should include the description of the program, why you are conducting and implementing the program, and the results that you might expect. And it will also really help to describe the process for implementing the program. When you know what you're evaluating, you can then create and implement a program that will hopefully get you to the desired outcomes that you would like. And it also will facilitate informed decision-making because you're collecting information about your outcomes. You'll be able to make informed decisions about the way forward and changes that may need to be made. Another big benefit of evaluation is that you're able to demonstrate your results and communicate that to others who may want to replicate that work. So the CDC framework for program evaluation in public health has truly been such an asset to this work. I will say that when we first started in 2019, we were using a different evaluation strategy. And so you'll note there have been many changes that we've made in our evaluation, including we started with the results-based accountability framework, which some of you might be familiar with, starting with the ends in mind, but we really felt, and I myself as the primary evaluator and coordinator of this program felt it was a strong framework with which to structure our evaluation. And so we wanted to use this evaluation to inform strategies that promote maternal and infant health outcomes by enhancing the systems that prevent family homelessness and serve pregnant district residents experiencing housing insecurity and homelessness. The CDC framework for program evaluation in public health was a great resource for that because it has guided CDC and external evaluator work since 1999, since it was released. It's been used broadly all over the world and cited as well in many peer-reviewed articles. And I did want to note there's an update that's planned for September 2024. I believe that the great folks at CDC will be working to review and really revamp the project, the framework so that it can remain relevant and available for use to evaluators for years to come. So I will be going through the steps of the evaluation, but before I do, I would like to just talk briefly about the overarching standards of the framework. And so there are 4 of these standards, and each of these standards also have a set of standards in the original framework that can help you assess whether the elements of your evaluation actually meet these standards. So the first is utility, to ensure that the information needs of evaluation users are satisfied. We're collecting the information that we do need. Feasibility ensures that the evaluation is viable and that it's pragmatic, that it's feasible, of course. Propriety ensures that the evaluation is ethical, that we are conducting an evaluation with mind to respect the rights of individuals who are involved in research and respect the populations that we are looking to work with and who we may be collecting information from and who are the results of our evaluation may impact, as well as accuracy, ensuring that the evaluation procedures and findings are done in a way that will yield credible results. And so as I go through the steps of the framework, I want to ensure to really call attention to these standards that should be considered in every step of this framework when you are conducting and developing your evaluation plan. So now I'm going to take you all a bit into from planning to practice, how in the DC CASI project, I have taken the framework and implemented it in use of our evaluation plan, as well as how it's changed over time. And so I mentioned that the project began in 2019, and we had many changes that happened, as you all know, in 2020. And so when we're looking to ensure that we had an effective evaluation that would reflect the work that we're doing and the outcomes that we wanted to see, we decided to develop this timeline based on the CDC framework, which started, it goes from 2021 to 2022. I'm going to go through each of these steps in the framework, as well as talk about how we utilize them in our project. And I do want to call again to the bottom of this image where you'll see a double-sided red arrow where the 4 standards of the framework are again restated. So the first step of the framework, of which there are 6, are to engage stakeholders. Many folks may be familiar with community outreach efforts where in the past you might go and pass out flyers and inform people of how to eat healthy or that they should go and get prenatal visits, something to that effect. I do want to note that engagement is seen to be something a bit different because it's seen as a bidirectional interaction between whoever is the primary evaluator, for example, and the stakeholders or communities that they want to serve. So this is a very broad framework. It can be used to encompass many different situations. And so your stakeholders may be CEOs, they may be hospital administrators, or they may be individuals experiencing homelessness. And the steps of these framework are really applicable to all of those situations when you apply it in a way that's appropriate for your program. And so in this first step, we really want to identify why we are conducting this evaluation and who it will impact. Who are the expected users of the evaluation? When you complete your evaluation report, who do you really want to make sure is going to read it? And it would be a great idea to have those folks present at the very beginning to help you design that evaluation so that you can ensure that it's going to be as helpful and useful to them as possible. It's also really great to engage stakeholders or the end users of that evaluation at every chance that you get. And important whenever possible to allow adequate time for really meaningful and ongoing bidirectional engagement and planning while you're going through program implementation. Now, we know that the ideal doesn't always occur in practice. And so as I talk about how we went from our planning of step 1, stakeholder engagement, into practice, we really were facing limitations of time to effectively engage a broader cross-section of partners outside of the core team who was participating in the group, as well as the bandwidth of the stakeholders that we wanted to get in touch with to participate in an effort like this. And so we are mainly coming from government agencies where we have the ability to email another person in the District of Columbia and see their calendar and put an Outlook invitation there. And when we are working with housing services providers, caseworkers, managers, as well as residents, it's not as seamless as a process in terms of communication. And so we wanted to think about how we could best leverage the individuals who are at the table. And so that's what I mean when I say the DC CASI core team. Those are the government agencies that are involved in this initiative, as well as our community-based organizational partner, Community of Hope. We know that we have a great cross-section of perspectives identified. And so we wanted to leverage thinking about how we can leverage those perspectives to have a longer term engagement plan that's really specific to the folks that we wanted to talk about, who are housing services providers and residents with a lived experience of homelessness and pregnancy. And so we did not, as originally planned, have a sort of consortium of bringing all these people together and in one table, or more likely at the time, one Zoom meeting. We decided to pivot and use a different approach. In step 2 of planning your evaluation according to this framework, it's very important to describe your program. You'll want to identify the health issue and the needs that are to be addressed, talk about the resources that you have available and the kinds of program that you want to implement, as well as think about how your program activities are resulting in the desired outcomes that you'd expect to see. And just consider the environment and the context in which your project is existing. And so for us in the District of Columbia, we had a global pandemic happening. We knew that there was a lot of supports that were occurring that were available to individuals to stay in their home. And so we certainly made sure to stay abreast of those programs, which were helping to keep people stably and safely housed, as well as keep an eye to what was happening with shelters and other congregate settings. What was the volume like? What was the need like? And what services were there to meet that need? What different kinds of things we may have been seeing that can inform the way we want to implement changes or recommendations to better support individuals who are experiencing homelessness and pregnant, to have support and safe and stable housing in such a complex time. And so initially we did plan to have, with this larger group, some sort of stakeholder vision setting and prioritization, as well as convening strategic work groups. And so these would be work groups of stakeholders that would meet at a periodic basis, discuss particular areas of focus, and come up with recommendations to enhance or to promote great assets that already existed. And so we did pivot a bit to ensure that before we got started with any sort of broader effort, there was so much more that we could learn from each other and each other's agencies. The agencies that are partnering in this work typically hadn't worked together before. The Department of Health, of course, knows that housing is a determinant of health, but we are not involved in issuing vouchers for Section 8 or placing individuals in public housing. And so there was a lot to learn about the ways that other agencies function, and where there may be overlap or may not be overlap, so that we could cultivate a shared understanding to move forward. We also really explored the policies and practices across the DC housing assistance system and the healthcare system, as they were relevant to our population of individuals who are pregnant and may be unhoused or at risk of homelessness. And this really allowed us to identify assets, gaps, and opportunities for improvement in these systems. Step 3 in the framework is to focus the evaluation design. In this time, you really want to get concrete about what you will do to measure the results of your implementation project. And so you'll want a program evaluation timeline, budget, and resources. You may want to create a logic model or source validated instruments if you're doing a kind of project that is going to benefit from a survey with questions that have been scientifically validated. You'll want to identify your process and or outcome measures and prioritize which of those evaluation questions you're really going to focus on. And again, remember to have some flexibility in your plan in case, for example, you're planning to do in-person surveys of individuals who are unhoused on the street, and it's no longer safe to do so because of, for example, a global pandemic. And these are all changes that this framework is flexible to. So we set out to create some SMART objectives and develop a theory of change for the changes that we proposed we might see based on program activities that would be generated by these larger stakeholder groups. So we did do quite a bit of pivoting. One upgrade, I think, was to implement SMARTY aims. And so SMARTY, the I is for inclusive and the E is for equitable. And that just adds another dimension of keeping in mind our equity goals while we're looking to measure and implement this work. We were able to develop a work plan and a budget to guide our stakeholder engagement activities, which again, we're going to be specific to our two target stakeholders, housing services providers and residents with lived experience. We received a no-cost extension to our grant, and so we were able to revisit the timeline and didn't have to do things in quite a condensed amount of time. And we also identified the need for additional resources, that we would need some academic partners to aid in data collection and analysis, as well as some vendors to help us to pull together some of our learnings and develop reports that we could share with others to really disseminate our findings. Step 4 in the framework is to gather credible evidence. And the key there is evidence that's going to be credible to the end users of your evaluation. This will vary depending on the purpose of your evaluation. If you are looking to provide a report to hospital administrators about patient satisfaction, it's likely going to be a different kind of data collection process than if you're talking to young people and you want them to learn about why it's so important to be mindful of climate change in the environment, for example. And so you'll want to select methods that are most appropriate for your specific evaluation needs. You want to define the roles and responsibilities of your program staff and other partners so that as you go off into completing these activities, everyone is aware of the role that they play. And again, set a timeline, yet remain flexible to unexpected changes that may need to occur. So step 4, oh yes, I did talk about this a bit. We did administer surveys. We had surveys with housing providers, and we had about 30 providers answer our survey, as well as focus groups with about 24 folks. And we have a qualitative interview process that's currently being analyzed, where we have spoken to 20 individuals with lived experience of pregnancy and the experience of homelessness. And we're really looking forward to that analysis being complete and gaining those insights. And we also are doing some policy review of some things that are being done within the system to better meet the needs of individuals as times have been changing with, before, during, and now in our pandemic recovery. Step 5 is to justify your conclusions. You'll want to ensure that your findings are meaningful, useful, and that they're going to be able to be used. You'll analyze your data and engage stakeholders in interpretation and confirmation of your findings and interpretations. So it's really great to allow time for this process. In our work, we were able to report out results from our survey to a broader stakeholder group meeting at the Interagency Council on Homelessness so that they can confirm that the answers that we received from them in general sounded accurate to them. And we also had a process where we returned results from our focus groups to those participants and ensured that nothing was misinterpreted. And we did have one change. I think it was something like a number that was wrong, and the participant was able to help us correct that so that that information could be appropriately communicated. And step 6 is the last step, though this is an iterative process and can be used for multi-year evaluations and longitudinal evaluations. And so that's to ensure the use and to share lessons from your plan. This is something that's really important to keep in mind from the start so that the information that you're gathering and the way that you collect and report it is going to be amenable to use for the folks that you want to take advantage of that information. And so we are now at a place in our project where we are holding periodic working meetings. We're developing our initial and finalizing our findings and recommendations. and planning for sustainability and dissemination and communication of these findings. That's where one of our vendors comes in, who is going to help us to develop one comprehensive evaluation of our initiative and the work that we've done, as well as some of the elements that contributed to our successful collaboration. And we'll also be developing a framework based on our collaborative model that we hope other district partners will adopt and use to address population health issues across sectors. And so this is just a flyer from the DC CASI initiative, showcasing some of the findings that we've had and talking about how we're making a lasting impact. But I know I'm getting low on time, so I won't get into too much detail there. And I do just want to leave with a couple of notes. Again, as collaborative as you can be is ideal, because multiple perspectives can really contribute a lot to the effectiveness and the comprehensiveness of a plan. As one person and one evaluator with experience, it's certainly you're going to be able to design an evaluation that will give you results that you feel are important. But the more individuals who are involved in that planning and implementation process, I believe the richer the findings and utilization of that information is going to be. And in terms of evaluating collaborative initiatives, I really think it's just important to note how unique every initiative can be. There are a number of issues that are being addressed through collective action and collaborative multi-sector initiatives like ours. And I would really love to see more initiatives sharing their processes and results so that we can continue to learn and advance how effective we can be in improving population health. So there's my reference, and I would love to take any questions. And that's me at the Cherry Blossom 5K on Sunday. So I hope you'll allow me to brag a bit.
Oh, excellent, and congratulations on that. Thank you. Thank you for an excellent presentation. The audience is welcome to enter questions into the question chat. And while we wait for questions to come in, and they're starting to populate, but I'm going to take the moderator's prerogative and ask, in thinking about the framework and as an evaluation expert, you'd mentioned too that there's an update planned for the framework for program evaluation in public health. What thoughts do you have, or what you would like to see in the update that's coming up in the framework for program evaluation in public health?
Thank you so much, Bob. That's a great question. I truly appreciate the initial document that was released with the framework. Of course, as with everything that CDC produces, it was very thorough and really outlined a number of standards in the framework that can be utilized. I would really love to see in this new iteration more examples of this work in practice. I mentioned that for many evaluators and many folks doing collaborative initiatives, it can be challenging to find examples of successful initiatives or even lessons learned, perhaps from other projects that may not have gone according to plan. And so finding a way to either integrate practice lessons learned into the framework documents, or to have a complement to the release of the new framework that might be a series of webinars where evaluators talk about their experience using this new framework, would be very helpful for me. So a very practice-focused response, I think.
Thank you. So very practical. Okay. A question did come in, and from the evaluation or from other work that you have been involved with the project, were there any findings or lessons learned or other information about teens, specifically about adolescents, homeless, house insecure, displaced, pregnant teens or teen mothers?
So yes, I can speak specifically to our context in the District of Columbia, and I think that it may be very different depending on where you're located. But here we have a couple of unique findings and challenges when it comes to young people who are the head of household and have children. One of those being, anecdotally, we've seen that when a young person becomes pregnant, and they're living in their parents' home, this may be a precipitating factor to their housing insecurity and experience of homelessness. It may be that there is not a family that is accepting of the pregnancy and will not allow the new parent and infant to continue to live in their home. And so we know that that has driven, at least anecdotally, some young people to seek housing support services. We also know that there are young people who have been engaged in the foster system. And so those individuals would already be sort of head of household. They would not be living with parents. They may be living in a congregate setting in the district where we have resources to support individuals who have been living in foster care and are transitioning into adulthood. And that was a unique situation that we want to be sure in our recommendations to highlight and to recommend that there's particular attention paid to this population so that their unique needs are going to be met.
Thank you. It seems like at times one of the challenges is with dissemination of findings. What do you think, what would you say are some best practices that you know of or guidance that you would have for others who are embarking on program evaluation, particularly around dissemination of results to residents and affected communities?
Oh, that's a great question, Bob. Thank you so much for sharing. I think that when you're talking about dissemination to residents versus public health practitioners, where you might go to a conference or look to publish something, I've felt that there's so much value in reaching out to our partners who are already connected or engaged in this work or similar work, talking to them about the goals that we share and how the information that we're finding can be beneficial to the people that they serve in their program or in their network or on their listserv or at their community town hall meeting. And so leveraging connections within our existing partnerships, which have been really strong, thankfully, and using that to be able to connect with people who work in the housing supportive services system, or also residents who are experiencing or have experienced homelessness, or just live in the community where we are all impacted by individuals who may be unhoused, because it's something that does have an impact on our society as a whole. And so finding partners who share similar goals or populations of focus, and talking, and I mean this in a very respectful way, not in a way to say that, because we are both working in this population, I just want to go and have a presentation to your group because I like to talk about the work that I do. But let's think about what is going to be most beneficial for this audience, how we can provide some added value and find a way to get the information out there in as many venues as we can.
Thank you. Let's see. Feel free, if others have questions, to enter questions. Related to that, I think, is there anything that you would, it sounds like there would maybe a similar factors that go into the beginning in terms of engagement with residents, communities, and interested parties. Is there anything else in terms of on that side that you would recommend to people, or that you have learned from your experiences that would be helpful when sort of embarking or planning on an evaluation project?
Could you please repeat the question, Bob?
Sure. Thinking about on the other side, as opposed to dissemination of results to residents and communities, is there anything? Is there any other factors that you consider, or best practices that you think of when engaging, when developing an evaluation plan, and engaging with residents and affected communities, sort of to get feedback and sort of on, engaging with them on an early stage? Is there anything that are there any other factors that you think of apart from when you think of dissemination?
Mm-hmm. Yeah, so it sounds like you're talking about when we're starting, how we're engaging stakeholders so that when we're looking to disseminate, we can have a more effective way to do that, or even
Correct.
the information
or
we're
even,
collecting.
Right, like trying to guide the evaluation, in a way that is most, most relevant and ethical, an optimal evaluation.
Absolutely, Bob. And that really just brings to mind that, speaking from someone who works within a government agency, I think it's natural that the questions that we will have and the outcomes that we might want to see might differ from the questions and outcomes that a community member or resident with lived experience may be interested in. And so I think having that awareness at the outset that whether or not you're able to effectively engage stakeholders at the outset, leave room for those insights, because there's no way to plan for voices that you're not able to hear at that time. So that's one thing to be mindful of. And then when you do have the opportunity to engage stakeholders, which I think that there are so many great examples in the district of groups that are working with community members that are available as resources that we can connect to, that we can really learn from. And that's the key, I think, to approach it in a learning stance and being available and ready to learn from stakeholders, from partners who may be able to share a different perspective or uncover additional populations that will be affected that you may not have originally planned for when you were having sort of closed door discussions. Really being open to learning from partners and stakeholders at every level has lent a lot of added value to our evaluation design and continues to as well.
Okay, excellent. Well, thank you so much. I'd like to thank today's excellent presenters, and I'd also like to give a big thank you to Lillian Yang, Richard McCord, and Laverne Bates for all their hard work behind the scenes in putting this excellent session together. And as a reminder, continuing education credits are available, and please consult the Preventive Medicine Grand Rounds website for further details. The next Preventive Medicine Grand Rounds will be May 4th. Hope to see you then, and that closes today's session. Thank you.